So welcome everyone to Project Echo. Today is Wednesday, December the 3rd, and I'm Lindsay Zimmerman with the Tennessee Department of Health. So for today's discussion, we're going to have a presentation from Dr. David Kursky on metabolic dysfunction associated steatotic liver disease, or some folks call it MASLD or MASLD, in patients with hepatitis C infection. We will have two case presentations, and then we will have an opportunity at the end for a question answer session. Just a reminder that if you are interested in receiving the continuing education credit, it's not a requirement to participate in Project Echo. However, if you are interested, it is a free 1 hour credit, and you need to register through the Southeast AIDS and Education Training Center. The link is in this slide, or you can also use the QR code, as it is a separate registration process. You do have to attend the full session to receive the credit, and then you will receive a post-evaluation survey to complete, and your certificate will be emailed at a later date. So just a few reminders. Kimber has included her information in the chat, but if you do have any technical issues during today's session, please do not hesitate to reach out in private chat Kimber Miller. Again, her information and contact is in the chat. So for the sake of time, as this is a very interesting presentation today, I am going to go ahead and turn it over to Dr. Kursky. Dr. Kursky is with the Northeast Regional Health Office in Johnson City and up in East Tennessee, and he is the medical director with the Tennessee Department of Health. So welcome, Dr. Kursky.
Thank you. Yeah, so just my background, I'm a family physician, public health physician here at the health department. And we treat hepatitis C patients in the context of basically uninsured health department patients. I can go to the next slide. Yeah, I don't have any conflict of interest. Next slide. So yeah, the acronym has recently changed. You may have known this entity as non-alcoholic fatty liver disease previously, and it's just recently changed. And you'll see and hear both of those names during this presentation. But basically, they can be used interchangeably. But defined as the presence of basically fatty liver, hepatic steatosis in conjunction with one or more cardiometabolic risk factors. And we'll talk about what those are here in a second. Says most patients are asymptomatic. I'm sure, patients do have some symptoms, but probably nothing that they would attribute to, something with their liver, most likely. And often it's an incidental finding, steatosis at least, some kind of imaging, or just increased liver function test results. Next slide. Yeah, so as I said, it's the criteria for it is basically hepatic steatosis, usually through some kind of imaging that's discovered, and then any cardiometabolic risk factor. So it could be increased BMI, increased fasting serum blood glucose, increased blood pressure, high triglycerides, or other lipid abnormalities. Next slide. Yeah, so and then also the other thing is like the absence of other things that would explain the steatosis. So basically, what's the difference between the old version and why they renamed it? Basically, the main thing is that the new definition just requires at least one cardiometabolic risk factor be identified. But there's basically about a 99% overlap between the two entities, so they can really be used interchangeably. Next slide. So this is from the American Association for the Study of Liver Diseases. They put out basically guidelines for treating non-alcoholic fatty liver disease, and then the name changed. So kind of retroactively, they're basically saying you can read the old guidelines and then just substitute MASLD for NAFLD, wherever that name occurs. Next slide. So this is kind of a schema of the various names for steatotic liver disease. So metabolic dysfunction associated liver disease are those entities on the left. So it can either be just steatotic liver disease, or if the patient has evidence of fibrosis, then you would term it MASH, or metabolic dysfunction associated steatohepatitis. There's some overlap with alcohol-associated liver disease. And I won't go too much into it, but based on how much alcohol intake the patient has, they can either be MASLD predominant or ALD predominant. Then there's also other things other etiologies that can cause steatotic liver disease that would not be metabolic associated. So it could be drug-induced liver disease, and various other things. I have a slide with the differential later on. Next slide. So actually, this talk is very similar. I did a presentation earlier this year about hepatitis C and diabetes. And obviously, there's a lot of overlap because diabetes is one of the cardiometabolic risk factors that would, if you had fatty liver, that would kind of clinch the diagnosis. So we talked about 3/4 of patients with chronic hepatitis C have some kind of extrahepatic manifestations. And one of those can be type 2 diabetes and or insulin resistance. Next slide. So both insulin resistant and type 2 diabetes can exacerbate hepatitis C's pathogenesis because they induce fat accumulation in the liver, which can lead to MASLD. And that can further contribute to liver damage and fibrosis in a patient with hepatitis C, chronic hep C. Next slide. So, yeah, metabolic complications are associated with hepatitis C itself, both during chronic infection and post SVR, so after they've had treatment. Hepatic steatosis is linked to hepatitis C with a prevalence of anywhere from 40 to 86%. And steatosis in hepatitis C patients can be attributed either to direct viral effect on lipid metabolism, sometimes called viral steatosis, or metabolic syndromes associated with hepatitis C, like the insulin resistance or type 2 diabetes. It can also be pre-existing, so they could have had diabetes before they were infected with hepatitis C and had some degree of liver, fatty liver before that. Next slide. Yeah, so there are some similarities in fat accumulation in the liver between hepatitis C and metabolic associated steatotic liver disease. So hepatitis C resembles MASLD in terms of insulin resistance, metabolic dysfunction, and chronic inflammation of the liver. And they both can independently trigger liver damage. Next slide. So we talked about viral steatosis. There's been studies linking or showing an association between genotype 3 hepatitis C and viral steatosis. One difference is that viral steatosis can be reversible after treatment, whereas with metabolic associated fatty liver disease, basically, you may not see improvement after treatment of the hepatitis C, which is why we're going to talk about these patients may need to be followed long term. Next slide. Yeah, so there have been studies showing that often the steatosis, if it's associated with metabolic dysfunction, even after treatment, can persist. And this is especially true probably in people with obesity, diabetes, or dyslipidemia. Obviously, well, treating their hepatitis C may have some slight improvements, at least in the diabetes, but often these are going to persist, and these patients should be followed long-term for these conditions. Next slide. There's also been some evidence that hepatocellular carcinoma, there's an increased risk in patients with hepatitis C and MASLD. So basically, they recommend continued surveillance for hepatocellular carcinoma and control of cardiometabolic risk factors to mitigate the effect on future liver cancer in these patients. Next slide. So this is a little bit of a repeat of the previous slide. One thing I wanted to mention is in our uninsured health department patients, often they don't necessarily come with any kind of liver imaging. We often don't end up getting liver imaging just because they are uninsured. So we may not identify hepatic steatosis in these patients using things like FibroScan or MRI. Sometimes we'll get an ultrasound that mentions steatosis, but that's not very, ultrasound's not very sensitive, so cases can be missed by that. But we'll talk about later about, are there some things in our uninsured patients where we would want to go ahead and try to get imaging. Next slide. So I mentioned earlier that for a diagnosis of metabolic dysfunction associated steatotic liver disease, you have to exclude other causes, including alcohol. You can go to the next slide. We'll skip over that. And I did mention there was a slide for the differential. So this is a list of things that can cause steatotic liver disease that aren't necessarily metabolic dysfunction associated, including alcohol consumption and chronic hep C, specifically genotype 3. Next slide. So these are the recommendations from the guidelines. Basically, they recommend basically against general population-based screening for MASLD. I don't know if that'll change in the future with specific medications to treat it, which have just recently been FDA approved. But they do recommend that in high-risk individuals, like people with type 2 diabetes or obesity, that screening for fibrosis may be indicated. And for that, you can use non-invasive tests, such as like a FIB-4 score. So they do recommend all patients with hepatic steatosis rather, or clinically suspected MASLD should undergo assessment with FIB-4 to rule out advanced fibrosis. So they do mention that if the FIB-4 is more than 1.3, that you can use other tests such as like FibroScan, elastography, or ELF, which is a liver test, enhanced liver fibrosis blood test. Let's see, go ahead and go to the next slide. So the recommendations, basically from the guidelines, do say that like in the primary care setting, basically patients with suspected advanced steatohepatitis, so fibrosis or discordant non-invasive tests. So you get two different tests. One suggests advanced fibrosis and the other doesn't, that those patients should be referred to a specialist for further workup. And they do suggest that patients with some evidence of cirrhosis are at highest risk for liver-related outcomes, including hepatocellular carcinoma, and need to be monitored for decompensation. Next slide. Let's see, did it skip one? Or no, maybe it showed the one after. Okay, sorry. Yeah, go back to the diagram. Yeah, so this is in the American Association for the Study of Liver Disease guidelines. There's a link to it on my reference slide. But basically, they recommend to screen with a FIB-4 score if it's less than 1.3. Certain people, if you have a high suspicion that the patient might have MASLD, fatty liver disease, they recommend periodic screening with the FIB-4. They recommend if it's elevated, so more than 2.67, that they could be referred to GI or hepatologist for further workup. And then basically, if it's between 1.3 and 2.67, they recommend, trying to get some other thing to help with risk, to assess the risk for advanced fibrosis. So this could either be elastography or the enhanced liver fibrosis blood test. Let's go to the next slide. So one of the things they mention in the guidelines is that, the normal range, because it's estimated that 38% of the US population has MASLD, the adult population, that like the normal range on liver function tests that we get from our laboratory basically includes, like more than a third of the people on there have MASLD. So the normal range is kind of skewed up for ALT and AST. So just because their scores come back normal doesn't mean they don't have fatty liver, basically. And they say as a general rule, an ALT more than 30 should be considered abnormal or, have some suspicion that it could be fatty liver. Let's go to the next slide. So what do we do if we do have a patient that we think has MASLD? So up until, just recently, and basically our pharmacists, I don't know when the FDA approvals happened, but it was fairly recently for both drugs that are FDA approved, because these guidelines basically say there's no FDA approved drugs. But the primary treatments have been basically lifestyle interventions, so weight loss, exercise prescription, and then for certain patients that meet the criteria, bariatric surgery have been the main things that the guidelines recommended for treatment. You can go to the next slide. Yeah, I basically included this because when the guidelines came out in 2023, there basically was not any FDA approved medications for this, but there are now, which we'll talk about. I'm not going to talk about treatment necessarily, but I'm going to talk about the treatments just for awareness. So yeah, you can go to the next slide. So there are currently 2 FDA approved treatments. So one is resmetirom, and this is for basically F2, F3 fibrosis, basically MASH with F2, F3 fibrosis. And then the other one is semaglutide, has also been FDA approved for the treatment of MASH, and also for F2, F3. And I'll just mention a few things about the drugs without, I've not used either of these to treat fatty liver myself, but I'll just mention some things to be aware of about these two drugs. Go ahead and go to the next slide. Yeah, so resmetirom is an oral liver-directed thyroid hormone receptor beta selective agonist. So it's kind of a mouthful, but basically has gotten FDA approval for the treatment of, like I said, F2, F3 fibrosis in adults associated with MASH. Not currently approved for those with cirrhosis, so stage 4, or with significant portal hypertension. Go ahead and go to the next slide. Again, it's a thyroid hormone receptor beta agonist. Helps reduce fat buildup in the liver, basically. Go ahead and go to the next slide. I guess some things to consider. Again, it's not for people with compensated or decompensated cirrhosis. They recommend a thyroid function assessment, so it's not recommended in someone with untreated hyper or hypothyroidism. And it's also not recommended for patients with symptomatic gallstone-related conditions. Go to the next slide. So I didn't like the liver, the Liverpool drug interaction checker does not seem to have, because resmetirom is so new, it doesn't seem to be in there. So I wasn't able to check through there, but I checked through some other things. There is some potential drug interactions between it and some of the direct acting antivirals. So just be aware of that and check for interactions. And, patients may not be able to be treated with both at the same time. Next slide. Yeah, so GLP-1 receptor agonists, semaglutide, has approval again for F2, F3 fibrosis. The main drug warning that I got when I looked at that was just basically the warning for all direct acting antivirals that they potentially could cause some hypoglycemia on patients taking other medicines that cause in conjunction with the DAA can cause hypoglycemia on patients taking semaglutide. Next slide. Let's see. Yeah, we won't necessarily go into all the details. Like I said, I'm not going to try to tell you how to treat patients for MASH, but just some things to be aware of. Go to the next slide. So there are some medicines that have been looked at for treating fatty liver and found that they don't necessarily help fatty liver. So things that aren't necessarily recommended. So things like pioglitazone and vitamin E showed some promise, but they've not really been shown to reduce, have any effect on the actual fibrosis. So at least these guidelines don't recommend using either of those. Other things, metformin, DPP4s, statins, milk thistle. The guidelines say have been well studied and should not be used as treatments because they don't have any meaningful benefit in the actual liver. Statins, however, are safe to use in patients that have, lipid disorders and fatty liver. So often patients will have, high cholesterol, high LDL, and be on a statin. But basically, it's just saying the statins don't necessarily help the liver or, prevent fibrosis. That's not been shown yet. Also, hypertriglyceridemia. can be treated with things like omega-3 fatty acids, fish oil, or fibrate. But again, those aren't specific treatments for the liver, fatty liver. Next slide. So basically, I kind of think of this, when I see a patient that we're treating for hepatitis C, we talk about the need for like ongoing harm reduction after if they achieve SVR. I basically tell them for the rest of their life they should be as nice to their liver as possible. So avoid alcohol, avoid medicines that are going to hurt your liver. So another one of those things that we'll need to counsel our patients on is basically if they have cardiometabolic risk factors for fatty liver disease, they should look out for that, take care of their liver by taking care of those cardiometabolic risk factors. Let's see, so lifestyle modifications. We try to give all of our patients a exercise prescription, but also, again, diet, and in some patients, bariatric surgery might be indicated. Yeah, so I think my next slide is the references. Yeah, so this is the guidelines from the American Association for the Study of Liver Diseases. And then there's an update that talks about semaglutide. And there's another update that talks about resmetirom. And then there's an update that talks about the name change from non-alcoholic fatty liver disease to MASLD. And I'll stop there. Thank you. Actually, I wanted to ask the pharmacist, do you know of any particular issues with either of those drugs and with us treating hepatitis C patients that I didn't mention, or did I say anything that was incorrect?
No, everything was good. Yeah, Resmetirom was approved last year in March. So yeah, it is. I checked in Liverpool as well. Yeah, it's not there yet. So hopefully that'll be updated soon. Now, as far as drug interactions, based on what you found and what I see, it's just automatic contraindication to all of the first line agents. So that includes ladipazole, sofosbuvir, patisiran, and glucocorticoid remdesivir, trade name Maverick. So all three of those have a contraindicated drug interaction. So that would be a conversation. Can we just hold the resmetirom if they're on that drug and need hepatitis C treatment? That would be the conversation we need to have. If that language is going to be remain that it's just a contraindication. It doesn't give much information as to what the issue is. So I'll need to do more research on that.
Yeah, and I couldn't find anything either. I also did see that resmetirom seems to have some level of drug interaction with almost all the statins, which you would suspect a lot of patients might be on. So that would be something else to look at.
Yeah, I don't have much experience with it yet. I do know about it and have helped talk about getting a person started on it, but haven't prescribed it or been a part of it just yet. So yeah, new drug to me too. But I know it's in the works to be more readily used in a lot of patient populations.
Thank you.
Thank you, Dr. Kursky. It was a great presentation. Does anyone have any questions or comments that they would like to come off mute and ask? Okay, I don't see anything in the chat either. One question I would ask, and I know clinical experience wise, as far as cheating or treating, since these medications are fairly new, I know costs could be of concern for, uninsured patients needing these particular medications. I know, especially with like Wegovy, for instance, or semaglutide, there can be some patient assistance available for certain situations. Do we know if patient assistance is available for the other medication as well?
Yeah, I was going to check that today, but I didn't get around to it. But that's definitely a good question. Yeah.
Okay. And did they say they were going to send over new blog?
I can look it up in the meantime. I have not been asked to look up. I'm sure it has patient assistance, but I'm not familiar with it. But I'll check and see if it's got a application and things.
No problem. Thank you. Yes, Dr. Horton, we will, our sessions, the actual didactic sessions are posted online, and I can send you that link after the completion of today's session. Everything is included except for the case presentation. So yes, you can get a copy of the slides. Does anyone else have any questions or comments before we move forward?